Welcome to CME on ReachMD. This activity titled Mastering Mutation-Driven mCRC From Testing to Targeted Therapy is provided by Agile Education. Prior to beginning the activity, please be sure to review the faculty and commercial support disclosure statements as well as the learning objectives.
This is CME on ReachMD, and I'm Dr. Cathy Ng. Here with me today is Dr. Scott Kopetz. Dr. Kopetz, can you tell us about novel anti-EGFR combination strategies in metastatic colorectal cancer, and what is the latest information available?
Thanks, Cathy. It's an exciting area. We are seeing a lot of advances on how we utilize EGFR inhibitors. And I think the more recent data has really reflected the use of EGFR inhibitors, the blunt feedback mechanisms from KRAS and BRAF inhibition, as well as thinking about how do we re-challenge patients. So the KRAS data, we know that the KRAS inhibitors are approved, both adagrasib and cetuximab, and sotorasib and panitumumab on the basis of response rate of 34%, PFS of around 7 months for adagrasib, cetuximab, and then the data from CodeBreak for sotorasib and panitumumab showing 26% response in the dose optimization for that combination, and then data from the randomized setting is really shown some improvements or benefits in PFS there. We're seeing the same with BRAF inhibition and breakwater study in first line. And I think what we're going to be seeing are more of these KRAS G12Cs being explored in the first line. So there's now 2 first line studies ongoing or announced for the G12C space. The other area of interest is thinking about the re-challenge. How do you take patients that derived some benefit from an EGFR inhibitor previously, and can you re-expose them to an EGFR inhibitor after some period of time away from the therapy? This is based on good science that says you can resensitize patients. At ESMO, we've seen continued data in support of this idea. There was the Prairie study, which looked at panitumumab followed by regorafenib, or the converse, regorafenib followed by panitumumab. And what we saw was response rates in the 16 to 18% for the panitumumab re-challenge in this setting, and the PFS for the panitumumab arm when compared to regorafenib was showing trends or evidence of improvement. The message from this and other studies like the amivantamab that it has a re-challenge arm as well, that's the EGFR bispecific, is the more time away from your prior EGFR inhibitor, the better. You get better response rates, better activity. The amivantamab, if you were more than 8 months out from your prior EGFR inhibitor, you had a median PFS of 7 months with the re-challenge. So these are real opportunities for patients.
That's a great summary, Scott. I mean, I think it really demonstrates kind of where the field is going in regards to selective treatment, with adagrasib and sotorasib. We're really excited about seeing some of that data in the first line and second line setting in combination, obviously in the first line setting in combination with chemotherapy. I saw some really intriguing data. I remember, I think it was from ASCO, John Strickler had done the smaller refractory patient population with fulvestrant combination with sotorasib. So I'm really excited and hoping that obviously at CodeBreak, I think it's 301, if I'm correct, is going to really make a big difference for our patient population. But obviously, as you know, KRAS G12C is only 2% of our patient population. But obviously, a lot of interest in a lot of the pan-RAS inhibitors, and really looking forward to some other drugs focusing on KRAS G12D. I thought the Prairie trial was very interesting about re-challenging, and I know you've got a lot of experience as well on this subject matter. And I think it really emphasizes to patients that that is a potential option, as you stated, when you've had at least a time frame of at least greater than 6 months. And I think it emphasizes the importance about rechecking the circulating tumor DNA again for RAS status and really determining whether or not it would benefit the patient. So it does open up a lot of new opportunities for patients. Well, this has been a great review of combination treatment strategies. Our time is up for this segment. Thanks for listening.
You have been listening to CME on ReachMD. This activity is provided by Agile Education. To receive your free CME credit or to download this activity, go to reachmd.com/CME. Thank you for listening.